Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today I have with me Dr. Nelson Leung, who is professor of medicine in the Division of Nephrology and Hypertension, and also in the Division of Hematology at the Mayo Clinic in Rochester, Minnesota. Everybody, I think, is aware that Mayo Clinic is one of the lead centers in the world on multiple myeloma. And Dr. Leung has got a very unique position in terms of being able to develop a whole career based on the patients with myeloma and other plasma cell disorders of the bone marrow and its effects on kidneys. He's a lead author on most of the seminal research that has been done in this area and guidelines. So I'm really very glad that he has agreed to be with us today to talk about myeloma and kidneys. Welcome, Nelson.
Thank you, Dr. Vij. It's a pleasure to be here. Thank you very much for inviting me for this.
So, how common is kidney involvement in patients with bone marrow plasma cell disorders and myeloma?
Yeah, so we have pretty good data on patients with multiple myeloma who have kidney involvement. And if you read the literature, you're going to get a number of different values because in different studies, the way that kidney involvement is defined is different. So in the kidney world, we arbitrarily assign that anyone with an eGFR or estimated glomerular filtration rate of less than 60 is those who have stage 3 chronic kidney disease. And if you use that parameter, about 30 to 40% of patients with multiple myeloma will have kidney involvement. However, that is quite generalized and is not very practical because in older patients, many of them will have an eGFR of less than 60. So if you use more stringent criteria like less than 30, then that drops to about 25 to 30%. And those are the ones, obviously, with more severe involvement of the kidneys with multiple myeloma, and they have more advanced kidney disease. And then if you look at patients that have that are on dialysis, that is about 2 to 6%.
Okay, interesting. So as far as the kidney damage goes in myeloma, what is it that is happening to the kidneys? Why do patients' kidneys get damaged in myeloma?
That's a great question. And so what is happening is that the plasma cells that are responsible for the myeloma, they produce immunoglobulins. And the immunoglobulins are antibodies. Now, normally these antibodies in small amounts are not problematic, but in multiple myeloma, the antibodies are produced in large amounts. And some of these antibodies are toxic to the kidneys, and they can be toxic to the kidneys in several fashions. So you have this diagram of a nephron, which is the units of the kidneys, and the glomerulus is where the kidney filters the blood. So what happens is that, especially with the free light chains, these can be filtered through the glomerulus and then go down into the tubules. Okay. Unfortunately, some of the free light chains can bind with a protein called the TAM horseball protein that is normally in the tubules in the loop of Henle. And when they combine there, they form these plugs that can obstruct the kidneys. We call these CAS, and this is how light chain CAS nephropathy develops. So a large amount of free light chain gets filtered through the glomerulus. They end up in the tubules in the loop of Henle. They bind with 10-horseful protein, and they form the plug. And light chain calciferopathy is now a defining event for multiple myeloma. However, there are other mechanisms where the immunoglobulins can also affect the kidney. So in the glomerulus, the immunoglobulins can actually bind to different components of the glomerulus. And this deposits of the monoclonal protein can also damage the kidney, either just by being deposited there, or they can actually activate complement, which can also damage the kidneys. Another way is that when the free light chain is filtered through the glomerulus, they end up in the first part of the tubule. And normally the light chains are reabsorbed in the tubules. But when this large amount of free light chain arrives at that part of the tubule, which we call the proximal tubule, these light chains get reabsorbed and they overwhelm the tubule. They injure the tubule, and some of them even form crystals in the tubule, causing damage to the tubules, and we call this light chain proximal tubulopathy. These patients typically will develop Fanconi syndrome, which is characterized by alteration in their potassium level, phosphorus level, and uric acid level. So those are the main ways that patients with plasma cell disorders and multiple myeloma have kidney damage.
So when you have a patient with myeloma, or you have a patient with a plasma cell disorder and has kidney dysfunction, is it always assumed that it is the underlying bone marrow problem that is causing the kidney dysfunction? Or are there situations where you need to figure it out by doing a biopsy?
Yeah, that's another great question. And unfortunately, the kidney only has a limited ways to tell us that it's injured. One, the serum creatinine, which is how we measure kidney function, will increase, telling us that the kidney filtering function has deteriorated. And number two, the kidney can spill protein in the urine. However, this is very common, and all kidney disease can present like this. And the more confusing part is that kidney disease is actually more common than multiple myeloma. So you can certainly have non-myeloma related kidney diseases in patients with a plasma cell disorder or myeloma. So in many of the cases, a kidney biopsy is required to make the diagnosis. Now, in multiple myeloma patients, if there were very high free light chain level, both in the blood and in the urine, and there is a very low level of albumin in the urine, then most of the time we can presume that these patients have light chain cast nephropathy. But other than that, it is almost always required to do a kidney biopsy to make sure that they have a kidney disease that is related to the plasma cell disorder or the multiple myeloma, and not a kidney disease due to something else.
So you mentioned that when a patient is diagnosed, they can have various levels of kidney dysfunction. You described the glomerular filtration rate. So obviously, patients are most terrified about having kidney failure and requiring dialysis. You mentioned that that's only 5 to 6%. So when you have a new diagnosis, or a patient has disease that has come back and requires dialysis, what kind of dialysis schedule do you put patients on? And is this something that is long-term, or is it something that can sometimes be for a limited duration of time?
Yeah, so in this country, if a patient needs dialysis immediately, then hemodialysis is the modality that we use, which is in your diagram, in your picture right now. This is a hemodialysis machine. And hemodialysis, as the name implies, we take the blood of the patient out. We run it through a filter, which will remove the toxins from the blood, and then we give the blood back to the patient. This type of dialysis is done 3 times a week, usually anywhere from 3 to 4 hours. Now, in other countries around the world, both hemodialysis and peritoneal dialysis can be done acutely, meaning immediately. So depending on where you are in the world, the type of dialysis that is started will depend on the modality that they use in that part of the world. And again, for hemodialysis, the patient will dialyze in a center 3 times a week. There is a form of hemodialysis that patients can do at home. And this home hemodialysis, patients generally will dialyze for shorter periods of time, usually about 2 to 2.5 hours. And they do this 5 to 6 times a week. Now, if you're in part of the world that uses peritoneal dialysis is done at home. And typically, patients will do this every day. It can be done several times a day where the patient will do what's called an exchange, or they can go on a machine called the cycler, and this will do it automatically for them for about 7 to 8 hours each night. And these are done fairly automatically. The machine will do all the exchanges for you. And all the patient has to do is connect to start at night, and then they disconnect in the morning, and then they go about the rest of the day.
And are these permanent or are these sometimes of a limited duration?
Yeah, so if a patient has what's called acute renal failure, meaning that the kidney failure was brought on very suddenly by the myeloma, about 50 to 60% of these patients can recover enough kidney function to get off dialysis. So the dialysis is temporary, just long enough for the patient to recover kidney function. However, if the kidney failure has been coming on over a longer period of time, which we call chronic renal failure, and in some patients with multiple myeloma, as I said, only 50 to 60% of them recover kidney function. For those who don't recover kidney function, then dialysis is more permanent.
And I understand there's another procedure somewhat akin to dialysis called plasmapheresis, which some centers do. Can you tell us a little bit about what this procedure is and what its role in the management of patients with kidney problems is?
Yes, so plasmapheresis is a therapy where we take the plasma out of the patient. So like dialysis, a catheter is inserted into the vein where we remove the blood. Now, instead of dialysis where we remove the toxin directly from the blood, in plasmapheresis or plasma exchange, the blood is separated into the solid component and the liquid component. The liquid component is the plasma. What we then do is that the plasma is tossed away, and we replace that with albumin or fresh frozen plasma. And that is returned to recombined with the solid part of the blood, which are the cells, and that is returned to the patient. The reason we do plasma exchanges, remember that in light chain cast nephropathy, the free light chain goes through the kidney and is combined with 10 horsepower protein to form those plugs. We do plasma exchange to try to quickly reduce the free light chain levels in the blood so that less plugging will occur. Now, there is some controversy with this, as not all studies have shown that plasma exchange has been effective in patients. However, I think that when done in the right circumstances, plasma exchange can be an adjuvant therapy to help the kidney recover from light chain cast nephropathy. This obviously has to be done with chemotherapy because although plasma exchange can remove the free light chain from the blood, you have to have adequate chemotherapy to stop the plasma cells from making the free light chain. So it's an adjunct therapy, is not a therapy to be done by itself. And I think that's a very important point to note, that by itself, it cannot reverse the kidney injury. It has to be done with the right chemotherapy.
So now that you bring up chemotherapy, what can you tell us about what are the best strategies in terms of giving chemotherapy for a patient who presents with kidney injury?
So that is another great question. And currently, the standard chemotherapy for multiple myeloma patients, newly diagnosed multiple myeloma patient, is usually a 3-drug regimen or a 4-drug regimen. And this includes the drug bortezomib or Velcade, Revlimid or lenalidomide, dexamethasone. And then for the 4-drug regimen, daratumumab or Darzalex is added. Now, of these drugs, Revlimid or lenalidomide is cleared by the kidney. And so in patients with kidney injury and reduced kidney function, the dosage of lenalidomide must be adjusted for the kidney function. In addition, lenalidomide is difficult to get in the hospital, at least in the United States. In Europe and other countries is not a problem, but in the United States, lenalidomide is very difficult to obtain. And so patients with kidney injury are usually admitted to the hospital to address the kidney problem. And because of that, it's difficult to get lenalidomide to complete the regimen. So we typically will substitute cyclophosphamide for lenalidomide while the patient is in the hospital. And in clinical studies, it turns out that bortezomib is probably the most important drug in terms of treating the myeloma in patients with kidney injury. Daratumumab has also been shown to be very effective. And so these are likely the 2 main drugs that are needed to treat patients with kidney injury. Cyclophosphamide and dexamethasone may help. Now, once the patient leaves the hospital, then lenalidomide can be reintroduced back into the regimen.
And I understand that often we give drugs to help bone health in our patients with myeloma. Are there any special recommendations for what agents to be used for bone health preservation in patients with kidney disease?
Yeah, so there are 3 drugs that are currently used for preserving the bone in myeloma patients. These 3 drugs are zoledronic acid, pamidronate, and denosumab. Zoledronic acid is the one that is most commonly used. However, zoledronic acid cannot be used in patients where the eGFR is below 30. Pamidronate can be used, and we actually use this drug even in patients on dialysis. There is no problem with using denosumab in patients with kidney injury or dialysis in terms of dosing. However, studies have found that patients can have very low calcium levels if they receive denosumab when their kidney function is low. And so in those patients, we have to use, if we decide to use denosumab, we have to monitor them very closely because they can develop low calcium levels for a long period of time. So of the three, the safest one to use is pamidronate.
And another thing that patients often ask is, can you do a stem cell transplant if I am on dialysis?
The answer is yes. Stem cell transplant has been done in patients with multiple myeloma who are on dialysis. The complication rates are a little bit higher, but not so much that it is prohibitive. Specifically, the recovery time for the red blood cells is usually prolonged. So it takes a little bit longer for the red blood cells to recover and engraft. Infection can be slightly increased as well, depending on the method of dialysis. And sometimes the dialysis modality would have to change. So in patients who are undergoing hemodialysis, many of them may have a AV fistula, which is created to remove the blood and return the blood to the patients. During the stem cell transplant period, their platelet count of the patients can drop to such a low point that we cannot use the fistula. It is unsafe. And we may have to switch to a dialysis catheter in order to perform the dialysis. However, these are typically done routinely. And so as long as these things are planned out in advance, it should not be an obstacle for performing the stem cell transplant.
So you mentioned that bortezomib is a good drug, Cytoxan is a good drug, lenalidomide we have to dose adjust. Are there any other restrictions on our drugs that you would like patients to know about? Others which we include, carfilzomib, ixazomib, and before we'll come in a minute to the modern treatment for myeloma, which is going to be CAR T and bispecifics. But among the classical drugs, do you have any recommendations about some of the other drugs that we use for multiple myeloma?
Sure. So I mentioned lenalidomide or Revlimid needs to be dose reduced. Now, in that class of drug, thalidomide, which we don't use very much anymore, and pomalidomide do not need to be dose reduced, although oftentimes people will use a slightly lower dose with pomalidomide in patients with either reduced kidney function or on dialysis. In terms of the proteasome inhibitor class, bortezomib or Velcade does not need to be dose reduced, but ixazomib does need to be dose reduced slightly, but that's very standardized. In terms of carfilzomib does not need to be dose reduced in patients with kidney disease or kidney failure. However, carfilzomib does have a small risk of causing kidney injury. And so in patients who already have kidney injury, we need to be very cautious about using carfilzomib in these patients, and they need to be monitored very closely. Now, there are the newer drugs, such as the antibodies like daratumumab, isatuximab, elotuzumab. They do not need to be dose reduced, and they can be used in patients even on dialysis. Similarly, there have been reports that the bispecific antibodies can be used in patients with dialysis, and these are teclistamab and talquetamab. Both of those modalities can be used. We talked about stem cell transplantation, and this can be done safely in patients on dialysis. the melphalan dose will have to be reduced by 30%. But again, this has become really standardized. The one thing that is a little bit trickier is CAR T cell therapy. CAR T cell therapy uses fludarabine for lymphodepletion before the CAR T cells are infused. And fludarabine cannot, we don't have a good dosing strategy for patients who have low kidney function or on dialysis. This dosing strategy still needs to be worked out. So until it is worked out, CAR T cell therapy may be a little bit difficult to receive for those patients who are on dialysis.
So another thing that patients often ask about is, can I get a kidney transplant? And I know that as patients with myeloma are living longer lives and having tremendously better outcomes than just in the recent past, this is becoming a more commonly asked question. So what is it that you advise patients and actually other oncologists like us as well about kidney transplant and plasma cell disorders, myeloma?
So that's absolutely right, Dr. Vij. As patients are living longer and longer, and we have more and more treatment options, this question is being asked quite a bit. And what we recommend at this point is that kidney transplant can be performed in patients who have a very deep response. We would prefer that they have a minimum of a complete response. And in fact, ideally, they should have achieved what we call minimal residual disease, undetectable or negative. So if they are negative MRD, then we feel that they could be a candidate for kidney transplantation. Another thing that we'll need to consider is whether they have high risk disease or standard risk disease. The reason for that is high risk disease patients tend to relapse more frequently, even when they achieve negative residual disease. And the reason we are concerned about this is that if the kidney failure is due to the myeloma, when the myeloma recurs, the same disease can recur in the kidney transplant, and we don't want them to lose the kidney transplant. So what we want to make sure is that they have a very deep response so that the recurrence will be delayed. And also we want to make sure that if they do recur, that we have medications that can treat the myeloma so the kidney disease does not recur in the kidney transplant. So those are the two main criteria we look at to determine if a patient is a kidney transplant candidate.
And overall, what is the prognosis of a patient who has kidney injury at the time of original diagnosis? Does this impact their overall long-term outcome?
Unfortunately, the studies have shown that even with the current therapy, having kidney disease and especially kidney failure does affect the outcome of patients with multiple myeloma, especially those who do not recover kidney function after treatment. So those patients who have persistent advanced kidney injury, which would be stage 4 chronic kidney disease or higher, or if they're on dialysis, these patients do have a poorer prognosis as compared to patients who never had kidney injury, or those who had kidney injury but recover to a better than stage 3 chronic kidney disease. However, the good news is that their prognosis are getting better and better with each additional therapy. As I mentioned, Velcade was a very important drug. It was the first drug that showed that we can improve the long-term prognosis of patients who have kidney injury in multiple myeloma. And I'm sure that the newer drugs, such as daratumumab, bispecific antibodies, will all show that they can also improve patient outcome in the long term. What we still need, though, is ways to help patient recover their kidney function. As I told you before, those patients who have kidney injury but recover their kidney function actually have prognosis similar to patients who never developed kidney injury in the first place. And currently, only about 50 to 60% of patients recover their kidney function. So we need to do better and help more patients recover their kidney function, and therefore we can really improve their prognosis.
So one of the things, I guess, it is a message that if you have kidney dysfunction, you need to try to start the treatment as soon as possible and not wait, because kidney function may not be recoverable if you wait too long. Is that a fair statement?
That's a very accurate statement. Studies after study have shown that rapid reduction of the free light chain is important for recovery of kidney function. And in fact, what a couple of studies have shown is that we need to get the free light chain level below 50 milligrams per deciliter or 500 milligrams per liter by the end of cycle 1 of chemotherapy. So it is very important that during that first cycle, we monitor the response to therapy very quickly. If the patient is not responding, we may even have to change therapy before the end of cycle 1. And that's where plasmapheresis and other extracorporeal devices come into play, that if the free light chain is not coming down, is there other ways that we can bring down that free light chain until the chemotherapy kicks in to try to help the kidney recover? And so that's where the effort is being done at this point, is to how do we drop that free light chain level quickly during the first cycle, which is usually between 3 and 4 weeks of time of starting chemotherapy. We have to get that free light chain level down so that the kidney can recover and those plugs stops forming.
And that paradoxically is the catch-22 situation, because often patients with kidney dysfunction present a little sicker with myeloma, and often a physician's instinct is initially to try to not even give the full intensity of treatment in an effort to quote unquote not harm the patient, but sometimes you may harm the patient by not being aggressive. Is that fair?
That's a very fair statement, and I think that that actually is the that's actually in the heart of the debate right now. We do know that kidney patients are sicker, and treating them too aggressively could lead to infection, but not treating them aggressively enough could also delay or even inhibit the recovery of kidney function. And I think that moving forward, what we need to do is come up with therapies that will increase the efficacy, but decrease the risk of infections and other complications to the patients with kidney failure, because they are more frail than patients without kidney failure. And I think that, but definitely we cannot go too gingerly with these patients, because if we don't treat them aggressively enough and we don't bring the free light chain level down, then we actually hurt the chances of the kidneys recovering from the light chain calcification.
Well, Nelson, I really value you having taken the time to go over these issues. You're the person who's written the textbook on kidney problems in myeloma, and it's really a privilege to have you on the program to talk to our audience about this, and I hope I can draw on you in the future to tell us more about the kidneys and myeloma as we go down. We're going to have new drugs and how they are impacting and changing the outcomes of our patients.
Absolutely, Dr. Vij. It's a pleasure being here today, and I'm glad I was invited uh, for this discussion, and I look forward to talking to you more about this in the future.
The privilege is mine. Thank you.